Back to part 2 of pharmacokinetics. So here we're going to be looking at all of administration and the different types of clearances and all the equations related to those and how we work it out. So here on the left you can see that initially, so this is time on the x-axis and plasma concentration of the drug on the y-axis. So you can see here initially the plasma concentration increases as time goes along. So this phase here is known as the absorption. So let's draw this out. So we have time concentration here. So what we have is something like this. So initially right now this bit here is 1, I'm going to leave it here, to the absorption so this is plasma concentration increases as the time goes on because once it's administered, so here is 0, the drug is being dissolved and it's being increased, so the concentration of it increases in the plasma concentration. Now here is distribution, so it gets distributed to different parts of the body, tissues and so on. Around here is metabolism, so the first pass effect, the liver metabolizes the drug, and around here it's what's known as excretion. So you can see here, this is the absorption. Here, somewhere around here, it's distribution. Here is metabolism, and then elimination, so the drug gets cleared off. Now, the half-life could be worked out from, if you remember from last, or if I use a different color. So that, let's just say this was 1. Half-life will be half, so 1 milligram. So it'll be 0.5 milligram. And you go across. And you come down, so you can find half-life. Now, half-life is not done. The major mistake what people do is they do half-life using drug in the whole body. So this is just drug in the plasma, so you don't use that. So you have to use in the whole body. Now, this bit here is known as Cmax, and the line which is drawn down here is known as Tmax. So this is the time when the concentration is maximum within the body. Now all absorption and barriers. So we have dissolution, then we have these over here are known as enterocytes. So this is the epithelial cells that surrounds the small intestine as well as the stomach and everything. So they carry out drug metabolism. They also have something known as efflux proteins on their surface. So I'll just draw them out. These efflux proteins are present here, here, here. So these are factors that can affect drugs from entering into the blood circulation. So what happens is a drug comes along, but the efflux proteins doesn't let it enter, so it gets pushed out. Now, even if a drug is successful at entering, so if once it gets in, it has to undergo drug metabolism within the enterocytes, and then in via the portal vein, where it goes into the liver, where the majority or the main bit of metabolism takes place. Now we'll look into a bit more detail on that. Sometimes what can also affect is dissolution, so sometimes drugs are not fully dissolved in the blood. So you can see initially, if you follow this drug here, this red bit here, it goes down into the esophagus, down through the fundus of the stomach, around into the bile-ductal antrum, through the duodenum, and then when it gets here, this is where absorption takes place around here, and then into the portal vein, and then that gets metabolized here, and then into the hepatic vein, and circulated back into the lungs, around the heart, and into the systemic circulation, so it goes around to the whole body. So these are some of the examples of these efflux proteins that I was mentioning before. So OATP is an efflux protein, influx protein, but so efflux and influx. So efflux includes P-glycoprotein PGP, MRCP2, breast cancer receptor protein BCRP, and OATP is a type of influx protein. So once a drug enters into the enterocyte, then it can be in the smooth endoplasmic reticulum. You have cytochrome P450 type enzymes and UGTs, which were in glucuronidation. These ones then further metabolize it, and then they're removed by MR3P in the basals, MRP3 in the basal side, into the portal vein, into the portal blood. Right. So the key one to remember is P-glycoprotein, MRP, MR3. The only one which is an influx is OATP. So model for drug efflux is shown here. You can see that this is an energy dependent process by which, so this is the cytosol, and this is the medium. This is how it gets in, so it requires an active process which requires ATP. Bioavailability initially was described as, if you remember back to the previous video, bioavailability was the amount of drug, or the fraction of drug that gets into the systemic circulation post administration. Now this is done by the area under curve initial concentration, or area under curve of oral divided by area of under curve IV. Remember, IV has a 100% absorption rate, whereas oral is much less due to the first pass effect, so it has to undergo via the small intestine, the gut, and then by the liver, so a lot is lost. So the first pass effect is essentially what I just said. So it's the amount of drug that is lost due to the first pass via contact with the gut and metabolism of the liver. Right, and this is basically 1 minus F. IV has a first bioavailability of 1. So first pass effect, so how much is lost in the first pass effect can be basically 1 take away F, and F in this case represents bioavailability. Essentially, this can be written as 1 minus area under curve for oral divided by area under curve IV. Now, ethanol estradiol, it's a drug which is used as an oral contraceptive taken by females. You can see here, initially, the initial concentration via IV, the plasma concentration when administered via IV is around 500, and then the oral one is only around 100 picograms. So this is in picograms, so, whereas it's 400. And this is due to the first pass effect, why there is a significant amount less. So Quinavir, it's an antiviral drug. Lovastatin is a statin. This is an oral contraceptive. So low bioavailability means these ones, there is a less concentration of these that get into the plasma from systemic circulation, and a lot is lost. So Quinavir, only 10% of what's initially administered gets into your systemic, and the rest 90% is lost via metabolism and excretion and so on. So here's a definition. First pass effect denotes the percentage of drug which is lost on the first pass through the gut and the liver following oral absorption. So it's first pass, it's specifically for oral absorption. If bioavailability is 50%, then 50% is lost on the first pass. Now, oral clearance can be oral clearance can be defined using the equation dose times bioavailability. So oral clearance, it's dose, or whatever you administrate, times bioavailability. So from that you would know how much of the drug that you administrate actually got into the systemic circulation, and then all of that divided by the area under curve. Now remember, if the area under curve was initial concentration divided by the rate constant of elimination. Or what you can do is, another way is oral, you can see clearance of oral is total takeaway renal no, that's not right. We'll get back onto that in a bit. So for now, all we need to know is dose times the bioavailability divided by the area under the curve. Now, in pharmacology, what we have is we have something known as, so this is the concentration, and here's the time. So these are different types of drugs we can have. So an example would be another one would be and the third one would be right. Now here you can see that over here it's the minimum, so this is the max and here's the min. So potentially you want a drug, so this is the minimum. So in order for a drug to be effective, it has to cross this line. But if it goes above here, so all of this, anything on top of this, it's toxic. So it leads to toxicity. So you don't want that. So preferable drug would stay in between as long as it can and stay here. So green one is the best drug. So you can see here. So that is the maximum effective drug. Right. So you want always drugs to be below the max, so that it avoids toxicity, but above the min, so that it is effective and it has a pharmacological effect. And you want the drug to stay in there the longest. Now, if we were to do some more questions, just to reiterate what we understood. So, drug X is administered orally. The fraction of the drug that escapes the enterocyte into the portal vein is 0.6. The fraction of this that escapes the liver to enter the hepatic vein, it's 0.5. Right, so what is a fractional? So you said that the fraction of the dose that escapes the enterocyte, it's 0.6. So what's the total? So what you do is 0.6 times 0.5, which is, you can simply do 0.3. Now what percentage of the drug is lost by first pass? So you know first pass is defined as 1 minus f. So it'll be 1 minus 0.3, which is 0.7. So what percentage? So you just times that by 100, and the answer is 70%. Equally, next question is drug X is administered orally. The fraction of the dose that escapes the enterocyte is a portal vein is 0.6, and the fraction of this that amount that escapes the liver to the hepatic vein is 0.5. Determine the oral clearance of the drug given the dose 500 mg and the area under curve of 0.6 milligrams per liter per hour. So in this case, what you want to do is use the equation clearance oral is equal to dose times bioavailability divided by area under curve. So what you do is the dose is 500 milligrams and you got F as 0.3, so you do 500 times 0.3 divided by 60. So that will be 2.5 liters per hour. That's the answer there for that question. Now to get rid of all of this. an individual with a high P-glycoprotein, so efflux protein activity, have obviously a low bioavailability. Give 4 reasons why bioavailability of an orally administered drug may be low. It could be due to enterocyte metabolism. It could be due to efflux proteins present on the enterocyte, dissolution, first pass effect, liver metabolism, drug-to-drug interaction, and so on and so on. Now we have what's known as hepatic clearance. So hepatic clearance, hepatocytes are the functional unit that form the liver. Right. Phase 1, cytochrome P450s. Phase 2, UGTs and sulfur transferase, that's what it means. Now you know transporters. So the key influx proteins are OATP and efflux 1 are MDR1, which is known as PGP, MRP2, MRP3, which is on the basal side. Now hepatic clearance can be defined using the equation CLH, which is clearance of hepatic, times Q times E. Right, E represents the rate of elimination, and Q is the rate of blood flow. So the blood flow and rate of elimination. So now, what we do is, so E is basically the fraction. So E is defined as, so concentration in take away concentration out divided by concentration in. Right, so that's what E is, and it's basically a fraction. So in this case, in this picture here, you can see that you've got 10 micrograms going in, and you've got a rate blood flow of 1.5 liters per minute, and then what comes out is 1. So you've got an excretion of 9. So 9 divided by 10 is 0.9, and you just simply multiply together. These different types of drugs: lignocaine, propranolol, morphine, analgesic, high-end analgesic, paracetamol, theophylline, diazepam, which is a muscle relaxant for. Now, extraction ratio is what E is known as the extraction ratio. So this is known as the extraction ratio. Right, so question: fractional bioavailability, assuming no gut loss, when hepatic clearance is 0.8 liters per minute, assume normal liver blood flow, complete absorption. Now, we have what we call different types of drugs, so generic drug products versus innovative. And here's a list of definitions. So we have branded drugs, which is what's usually administered from the pharmacist. And these drugs are usually provided or produced from an innovative drug company, rigorously tested, millions and millions of pounds, and it usually takes a very long time, about 15 years. And it has received the required approval by the country's organization and distribution. Qualified generic drug, it requires proof of bioequivalence. Bioequivalence basically means does this have bioequivalence? It's the effect divided by effect by generic drug or by branded drug. Times 100. Or you can compare it with other qualified generic drugs, and what you want to see is bioequivalence to be almost similar, so you know that these drugs all are effective in the same way and they're all equally effective. An unqualified generic drug is randomly clinical trials. They don't really have proof of bioequivalence, may lack body supporting evidence. Counterfeit drugs appear in both brand and generic forms. They're deliberately misled. They have no backing or no governing body to support them. Clear presence of incorrect ingredients, false packaging, not a viable treatment option basically. Now, a question here is: a drug addict is admitted to hospital having taken large doses of methadone 9 hours previously. An immediate plasma analysis shows a methadone concentration of 0.25. So initial concentration is 0.25 milligrams per liter. Assuming that the pK of methadone in the patient are pharmacokinetics of the methadone, so VD is 200 liters and a half-life of 3 hours. Calculate how much methadone the patient injected 9 hours earlier. Right? So you have a VD of 200 ml. So you know VD is equal to dose times initial concentration. So we want to find out the VD 9 hours before. So at 9 hours, when T is equal to 9 hours, VD is equal to 200 liters. Right? Now, VDs cannot change, so VD is always 200 liters. I'm sorry, when T is equal to 9 hours, initial concentration is equal to 0.25. Now you know it has a half-life of 3 hours, so if we go back, so if we start at 9, so it's 0.25, then we go to half of 9 is, no, it has a half-life of 3 hours, so we go down to 6, then that becomes double of that, so it'll be 0.25 times 2, 0.5, then half of that is 3, becomes 1, and then double of that is 2 and 0. So initial concentration, the administrated amount was, the concentration was 2 milligrams per liter. Now using this equation here, we can work it out. So we have 200 times 2, which is equal to 400. And you want to check the units here, milligrams. So the initial administrated constant drug dosage was 400 milligrams. So that's one of this video of clearance and how to work out the different types of clearance. The next video I'll go through how to work out renal clearance, then we'll do a bit more questions, and then that'll be the last of pharmacokinetics. Right, so thank you for listening. Again, all these lecture slides are all credit goes to University of Liverpool, Dr. Geoff Edwards, Dr. Jeffrey Edwards. So I'm just using this as a sample. Right, so thank you, and please subscribe and post any questions if you have any confusions, and I'll try to get around as soon as I can and answer those questions. Thank you.